Now I request Gita Sen to give a talk on UHC in India as seen by the high-level expert group. As you all know, she was a member of the HLEG. She's a professor. Dr. Sen is a professor of public policy at the IIM Bangalore, and she is also a member of the National Rural Health Mission Steering Group of the Government of India, and is of the governing board of the National Health Systems Resource Center. She is author and editor of several books and articles. Dr. Sen.
Thank you.
Before we started 1 hour late, may I request all the panel speakers to spend about 10, I mean, you were allotted 15 minutes, but I take the liberty of cutting to 10 so that we have some time for the audience to ask questions. Because we can't delay lunch beyond 2:30. I hope you've all eaten the biscuits. And don't fall asleep, 2:30 lunch.
Okay. Thank you. Thank you, Sujata. Let me say, anything that, therefore, that I don't say will be because of the chair. Let me just start off by thanking the Institute of Public Health, the Institute for Tropical Medicine in Belgium for inviting me to speak at this session in the second EPHP conference, and to congratulate the organizers for bringing it off a second time. I should also start with a caveat straight off, and that is I am not speaking here on behalf of the HLEG. In fact, the HLEG does not exist anymore. Technically, the moment we submit our report, we are finished. So we don't exist as a body. Therefore, anything that I say cannot be attributed to the HLEG. Wherever it is there in the HLEG's report, you can obviously find it, and I'm not trying to shy away, but I just wanted to be very clear. I don't want anyone saying, HLEG said this, because it may or may not have specifically said it, and wherever it is that there may be, in a couple of places, some distinctions which are not at cross purposes, but which are perhaps in hindsight some things later on. I'll try and point them out. I've also, when I thought I had 15 minutes, I was going to speak about not everything that the HLEG was tasked to do in its report, but simply 2 elements of it, which had to do with financing and regulatory challenges. Because in a sense, those 2 have become the lightning rod for everybody, all stakeholders, from the Planning Commission to the Health Ministry to private providers to everybody else, and of course civil society are all deeply concerned about these questions. But let me then start off very quickly by acknowledging the vast amount of public debate that, whether or not one agrees or disagrees with whatever the HLEG's report said, that this whole process has really started off in the country. And I think that, if nothing else, that has been useful. And just about everyone you can think of in terms of different perspectives and points of view has been a part of these debates. And one learned many things in the process of its happening. In fact, I did not know that there are actually 2, not 1, but 2 associations of unregistered medical practitioners. And they actually exist as formal associations, and we met with them, and then they were talking about what they wanted out of this process. Many of you know the membership. The membership includes a range of public health experts, community health practitioners, researchers, and very importantly, government functionaries as well. Part of the interesting post report dynamics that have been going on in the context of the 12th Plan chapter on health is who is and what positions they took when they were part of the HLEG's report writing and what positions they take at different points doesn't always stay the same, and it's been quite fascinating. One issue that came up very early on when we looked at ourselves when the group was appointed was say, where's the private corporate sector? Because it isn't there in this group. And at that time, Deputy Chairman Planning Commission said, well, you know, we hear from them all the time. And what we want is to create a group that will not, in fact, be dominated by them and will be able to do its report. And when Anne was speaking about having people inside the tent, I think the question of the importance of having people inside the tent has, you know, obviously come up at many points in the discussion. Our terms of reference were quite broad, and they actually are not about universal health coverage, but actually about universal health care, with that distinction being made. But as I said, I'm only going to speak about the couple of things that are in blue on this. The plus on the social determinants is that actually, and this goes to what Secretary Health said in his speech in the morning, the importance of the social determinants of health was that in fact it was not part of our original terms of reference. And we insisted on bringing it in. I don't think we've done an adequate job on it, but it was impossible in the time frame that was there for that to happen. These guiding principles, many people concerned with UHC have in fact endorsed some variant or version of these principles, including many from civil society, including MFC, the Medical Friends Circle itself. Very simply, the vision of the HLEG as put forward in its report was simply universal health entitlement for every citizen, to a package of essential primary, secondary, and tertiary healthcare services that would be funded by the government. And the package to be defined periodically by an expert group with possible state-specific variations allowing for the differences across the states. Now, the first issue, the financing challenge. Many of us know this data, and I'm not even going to hold this slide very long. The problems, huge problems on the financing side of health inequity, of impoverishment, the fact that over 40% of hospitalized persons have to borrow money or sell assets to pay for their care, the proportions of hospitalized persons who fall below the poverty line, and so on. And this kind of graph, of course, tells us that the numbers, the absolute numbers have been going up quite dramatically of those who've been impoverished due to out-of-pocket payments, roughly in the period of the economic reforms. What I call the 70-70 syndrome is another major part of the financing problem, which is current schemes for financial protection typically don't cover outpatient care, they don't cover drugs, and they don't cover lab diagnostics, even though they are meant to cover drugs. But together, these account for over 70% of out-of-pocket expenditures, which in turn account for over 70% or around 70% of total health spending. That means in India, differently perhaps from a number of other countries, if we can do something about drugs and ensuring access to affordable drugs within the system, we will in fact be able to go a significant way to dealing with the out-of-pocket expenses. And in fact, the HLEG identified this. Different state governments have put forward. We, in fact, did not feel this was the route to go. And let me just say very quickly why we didn't want to take this route. There have been two kinds of critique of RSBY and the other insurance schemes, the newer ones that state governments have put forward in India. The first one is that in practice, they don't really work to be inclusive, have many implementation problems, and this critique really focuses on the mechanics of how the insurance works or doesn't work, whether procedures impede access for the poorest, whether there is fraud, whether there is exclusion, inclusion, whether 14-year-old girls are being sterilized or given hysterectomies, as has happened in abuses in Chhattisgarh, Bihar, and so on, whether there's cheating on services. That's one set of critiques, and that's very similar to a standard sort of critique that we always get in any kind of government program. But there's a second critique, which probably from a longer term perspective is more crucial for these kinds of schemes, and that is the problem, the challenge of viability. Because the experience, particularly of RSBY, suggests that while it may be possible for the public sector through a set of different measures, including the use of IT and other things, to improve, to correct the first set of problems, the core problem becomes fragmented care. That is, it tends to push too many people upwards to hospitals for later and more expensive services because of the lack of primary and preventive services with quality. Now, the problem that happens here, of course, is that ultimately finances are limited. And if one says, well, can't one do this and do that? It becomes very difficult because in the end, the total amount of finances that one can garner or put together for health is somewhat constrained. And so if all of it goes towards the secondary and tertiary levels, then it becomes very difficult to move it towards the lower ends, which is clearly where it needs to be. The unviability of this kind of insurance model, and Kerala, for example, has had a problem that most BPL families, it being Kerala, tend to use their full entitlement. Now, no insurance scheme can work if everybody is using up to the limit of whatever it is that they are entitled to. So the insurance company then faces the following choices. Either discourage patients, or you track the providers very tightly. And this is something that many insurance companies actually aren't very good at doing. Or you bid higher or politically pressure for higher premiums, which is the experience in many of the states that have been trying to do this. Or you opt out. Say, can't do it on this premium, we can't do it. Then you get a revolving door of companies. Each year you get a new company coming in, which means, of course, that there's very little learning in the system. The presence of an insurance intermediary, a third-party administrator, really doesn't seem to hugely modify this. Andhra has tried to change how they run this and so on, but the problems still remain. And the fundamental problem of unviability and this fragmented care and pushing upwards towards unviability is, I think, one of the most serious problems. There's, of course, an additional important side issue, which is that all of these schemes are BPL targeted. Increasingly, of course, RSBY has expanded beyond BPL towards different kinds of informal sector groups, which may or may not belong to the BPL category. But overall, it's not the targeting problems and the transaction costs involved in ensuring that you're targeting right become fairly critical. This unviability was what led the HLEG to argue in favor of strengthening primary and preventive services in the public system, to strengthen the capacity of the public services, especially at the lower levels, to build regulatory and managerial capacity in the government, and to directly contract private providers to provide services if needed. And so that was the route that was taken. And some of this was one of the things that Anne spoke about as well as one of the options of which direction do you go. I might mention that among the groups that the HLEG spent quite a bit of time talking to were a number of people, including Anne and others, and no responsibility lies there, with a lot of the international experience to see what comes from the experience of countries like Brazil, like Thailand, Mexico, and others, both positive and negative. So in terms of financing and financial protection, general taxation was seen as the principal source for healthcare financing, complemented for middle class and other taxpayers and so on, with possible additional mandatory deductions as either as a proportion of taxable income or as a proportion of salary, similar to the cesses that we pay for other things. Secondly, that government expenditures on health were projected to rise from the current 1.4% of GDP to at least 2.5% by the end of the 12th plan, and at least 3% by GDP by 2022. And specifically on drugs, to increase public spending on drug procurement to about 0.5 percentage point of GDP as a way of ensuring free essential medicines in the system. Now, what did it not say? It didn't go the route of sin taxes. No specific sector-specific taxes on tobacco, alcohol, and so on. Different countries have used these. The HLEG sort of felt that we didn't want to go the route which would say that the more you drink and smoke and do the things that are bad for your health, the more money will come into the system for supporting health. It seemed a bit contradictory, and so we didn't take that route. Specific purpose transfers to equalize levels across states and to accept flexible and differential norms for financing proposed by states, recognizing obviously that there's huge diversity across the states, and no user fees for services. And this would, yeah, I'm wrapping up. This would apply even to those who have the financial capacity to pay. Primary health care should account for 70% of all government health care expenditures. And then, okay, can I have 2 minutes to do the regulatory challenge? Okay, it's going to come back. Okay. Purchase of all healthcare services under UHC should be the sole responsibility of ministries and departments of health at central and state levels. And I think it's important to say this in light of the post-report debates that have been going on and controversies around the 12th plan. The move from ad hoc PPPs towards a strongly regulated and managed system through systematic capacity building to design and manage contracts and strong institutions for regulation and accountability to the community. And we had put forward a whole architecture for what this regulatory system should look like. And I don't have the time here to go into the specifics and of it, but both national and state level, that there should be regulatory and development authorities with very specific mandates of overseeing and enforcing contracts, legal and regulatory norms for facilities, standard treatment guidelines and management protocols, enforcement of patients' charters of rights, adherence to standard protocols for treatment, and a system of regular audit of prescriptions, with a number of units envisioned that would actually make it possible for this to go forward. And very importantly, before jumping onto the drugs bandwagon, to strengthen the Drugs and Medical Devices Regulatory Authority and to expand its scope so as to better regulate the pharmaceuticals sector. And this is my last slide. You might say on the regulation side, this is aspiration. The situation right now is practically close to zero on regulation. We are so weak on regulation at this point that all of this seems like a dream, the dream in the title, or a pipe dream of different kinds. And I think it's important, and the HLEG felt it was important, to set forth both a vision as well as something of a roadmap, and that if we don't put that vision forward, we won't even know where we are trying to go. But And this is something that was not specified in the report, but we've talked about it, including to the Planning Commission afterwards, that we believe the key first steps need to be to increase public funding to strengthen public services, to implement the free generic drugs in the public system with effective regulations and controls, to set up the regulatory structures, which will take time, as well as the structures for accountability to citizens, and to devise the integrated package of services, and to move to contracting of private providers only after this is done. Thank you.
Thank you, Dr. Sen.